Thank you, Rupert. Thank you for inviting me to this course. The talk is slightly mixed. There are some facts about diabetes and cataracts. There are some things you need to think about when you're operating on a diabetic who has a cataract. And then there's some the last few slides are a practical plan on what I do and what maybe you should be doing. So you can take that home with you. Diabetes is an ancient disease, as we all know, but what is more important is that it's going to become more and more common for us. India is going to be the diabetes capital of the world. The maximum number of diabetics are going to be living in India. So all of us are going to be dealing with this. Put together with the fact that the people with diabetes get their cataracts about 10 years before people without diabetes do. So you can imagine what the scale of the problem is. Added to that is diabetic control, especially around Calcutta and Bengal, where I practice, is very, very erratic, to say the least. People have not heard of an HbA1c and have had diabetes for 20 years. A lot of people smoke and have other habits, have not had the lipids checked, etc., etc. So the incidence of diabetic retinopathy in Indian studies, in a South Indian study, was something like 66%. When they took it with cataracts, people with cataracts and diabetes, 66% had diabetic retinopathy. In the West, it's like 20-25%. So for us, the scale of the problem is even bigger than it is elsewhere, which is why this is important. Firstly, to get this rare entity out of the way, there's the true diabetic cataract, which happens in type 1 diabetics at a very young age, maybe 14, 15. The last one I operated on was 12. Presents with a rapidly maturing white cataract, which is the first case, or the classic snowflake one, which you see on the other side. But this is quite rare. You don't get that often. So that is not the main part of the issue. Those you just have to get on and operate in the next few days. You can't see the fundus. You do an ultrasound, you operate, and then you do what you have to do with the fundus. Like I said, the average prevalence of diabetes in cataract patients across the world is between 8 and 25%. If we translate that, forget about the bad control, to India, we're still talking 1.6 crores. So it's talking a lot of people with cataracts and diabetics who need to be dealt with. Now, when we think of cataract and diabetes, we have to think of them as separate classifications. What is the risk profile of this patient? Well, if they have no retinopathy, or mild background retinopathy, mild NPDR, without laser treatment, then they probably have similar outcomes to non-diabetics. You still do have to monitor them a bit more closely because they might develop things afterwards quicker. And they have other risks like increased risk of infection, but overall the outcomes are good. If they have pre-existing retinopathy plus minus treatment, then they usually have adverse visual outcomes. And I could quote a lot of studies, but that's the gist of what happens. So beware of when you're going into the operating room. Before that, you've checked try to control the blood sugar as well as you can. They don't dilate well often, so beware of that. They will develop post-operative iritis more often than others, so beware of that. They get increased PCO, so be very meticulous about cleaning out about your cortex, cleaning and polishing. And they run an increased risk of endophthalmitis in spite of everything we do. And when they do get endophthalmitis, they get worse outcomes than people without diabetes, so that's another thing. About 1/5 of people with diabetes and cataracts will show progression in the year after surgery. If it's monocular surgery, then it's about slightly under 40%. When you compare with the fellow eyes, 20% of them are still progressing because it's systemic disease. So it's not only the surgery, it's the underlying factor which is also doing it. So let's actually get to what do we do. We ensure good glycemic control as best as we can. Use very good technique. Shorten your operating time as much as you can, because the more fluid you're passing, the more risk of other things happening. And like I said, thorough cortical cleanup, a hydrophobic square edge, 360-degree square edge lens, and endophthalmitis prophylaxis, whether you want to give them moxifloxacin or cefuroxime, something into the anterior chamber, always is at least my practice, and I would highly recommend it. Now we move on to two different sets. There's cataract with people with proliferative diabetic retinopathy, and there's cataract with people with diabetic maculopathy. So first, to take on the PDR group, if you can see enough, then you do a PRP before a scatter photocoagulation, leave it for 6 weeks, 2 months, and then do the cataract. And that's standard. That's not a problem. The problem arises when the view of the fundus is not good enough because they've come to you with a fairly dense cataract. And the option then is really to do the cataract, and if you are able to do an indirect laser on the table, so they've had the PRP as soon as possible, or within a few days later outside if you can't do it on the table then. So really, I mean, that's fairly straightforward. PDR equals PRP. The earlier you get it in, the better. Usually people who have had it pre-op do better than people who have had it at the time of operation or slightly after the operation. So if you look at some pictures, the top line, the first picture, that lady had photocoagulation 20 years ago, had a dry macula, and she probably doesn't need anything else doing. There's no active new vessels, there's no macular thickening, and she was done normally, and she came up with 6/6 vision. The ones in between have what we call a non-proliferative diabetic retinopathy. As you can see, that's the middle line, the two pictures in the middle. These are patients I would not do anything extra for besides monitoring them a bit more closely later on because they might progress very quickly after the surgery. So I wouldn't be pre-treating them with laser or anti-VEGF or steroid or anything. And then there's the group on the last line, which is proliferative retinopathy or on fluorescein angiography, enormous areas of capillary fallout. I don't mean 10 disc diameters, I mean enormous areas of wipeout. And those I would PRP before I did cataract surgery if I could. If I couldn't, then I would do it during cataract surgery, just at the end of cataract surgery. If you get to cataract surgery with maculopathy, there's a clear risk of maculopathy worsening after phaco. Much less with phaco than with extracapsular, but the risk is still there. There's some evidence, some studies which say if you do an uncomplicated, nice phaco, then it may not lead to accelerated diabetic retinopathy. That comes from Sheffield, where I used to work at one time. But those are few studies. Most studies would suggest that they do progress. And who progresses? If you have pre-existing macular edema, you're almost certainly going to progress. If the severity of your diabetic retinopathy is more, you're going to progress. If your diabetic control is poor, you're going to progress. But you also must keep in mind that these patients are also prone to getting post-operative cystoid macular edema, so it can sometimes be tricky to differentiate whether they have diabetic macular edema or cystoid macular edema. Thankfully, these days, you can just put in Osiodrex and it'll treat both. So if you called it wrong, it probably didn't make a great difference. Or in fact, Accentrix. So what do we do? It's OCT-based mainly. If the view permits, you get an OCT. If the OCT is clear, like that, then you have no worries. You just go ahead and do your normal cataract, follow them up. If the OCT is like that, with quite a lot of fluid and thickening, then you have to give them something before you do your cataract surgery, usually an anti-VEGF. Usually Accentrix is my drug of choice at present. So you give them that, you wait for a month, maybe give them the second dose, and then you do your cataract. And then you give them the third dose later on. So under the cover of Accentrix or ranibizumab, while it's working, you get the cataract done and then follow them up just like you would any other diabetic maculopathy patient. And if you have something like that which has vitreomacular traction, then you're better off switching to a combined phacoemulsification and vitrectomy procedure. We don't have ocriplasmin here. The combined anterior and posterior segment procedure, because that vitreomacular traction needs to be removed. So the OCT will tell you your surgical plan as to what you want to do. If there's doubtful view, if there's a hazy view, the OCT is not quite good and you don't know what to make of it, it looks like there might be some maculopathy, but there is a history of maculopathy. Then I will often give them some intravitreal steroid during the cataract operation. just to tide them over the first few weeks. Ideally, you would give them anti-VEGF, but the economics of cataract surgery plus anti-VEGF at the same sitting may not suit the patient. So it's usually triamcinolone on the table. And one of the ways we do that is to just, instead of trying to inject pars plana, we just go through the zonules as a technique we published in 2005, which now the cataract surgeons have taken up. They're putting something called trimoxyvanc and no drops after cataract surgery for routine cataracts. But essentially the technique is the same. The only trouble is you don't know how much you've put in because some of it is washed out. So if you put in 2 milligrams, you've washed out some steroid, says some goes out. You don't know exactly how much you've put in. But it does sort of control it immediately in the immediate post-op period for the first month or so, giving you time to do your OCT, fluorescein, whatever you want to do, and then plan your further treatment as you want to. If you have no fundus view, then you do an ultrasound B scan just to check that there's no tractional detachment. You won't see fine detail. And you do a post-op OCT as soon as you can. Have a look on the operating table. If there's the PDR proliferative vessels, then do PRP right then and there. If not, it's difficult to access the macula very well on the operating microscope or on an indirect. So I would do that later on the slit lamp and then choose whether I wanted to give them anti-VEGF steroid or laser depending on various factors which you all know about. So that's really, I just wanted to summarize some sort of workable plan for people. So this is what you do when you see this patient rather than go into great detail. Thank you.